I'm Kevin Yeskey. I'm from ASPR. What I'd like to do today is talk a little bit about what ASPR does in this area, focusing on how we modify what we do based on objective data that we get from a variety of sources, and talk about a little bit about that, then focus in on some of the mortality piece, but mainly focus on the morbidity piece of what you're talking about today. Our role in the federal response system is to lead and coordinate the emergency support function number 8 responsibilities under the national response framework. And it's a national framework. It's not a federal framework. It's a national framework. We support state, local, tribal, and territorial governments. We don't go in and take charge. We support them. We work with them before the events, most importantly, so when there is an event, we all know one another, we know what the needs are and what the capabilities are and how we can do that. So we look at plans, we participate in exercises and evaluate and do things like that in advance of responses. So we have established relationships, but in ESF 8, there's 17 responsibilities, and they vary widely from victim identification, medical care, environmental health, food, water safety, amongst many others. And it's a wide swath. And we coordinate not only our department, Health and Human Services, but our partners from VA, DOD, agriculture, et cetera, to come in and assist us. It's a public-private partnership. Many of our programs, including the National Disaster Medical System and the Hospital Preparedness Program, depend on private partners. So all our hospitals in NDMS are private institutions. All our team members that come from our teams work in private or public hospitals, but they're private citizens who volunteer to work with us, and then we mobilize them and deploy them in times of need. The other thing about NDMS is that we have in addition to the field teams, we have a responsibility for patient movement, patient transportation. And it's not just to the next hospital down the street. Sometimes it can be to the next state, or skip a couple of states and go to another state, or from Hawaii back to the continental United States. So the transport is local sometimes and can be at great distances, and we've exercised that. In fact, we move people in Hurricane Maria, we move patients from Puerto Rico to Atlanta and elsewhere in the country. So there are distances involved. And then there's a definitive care piece of NDMS. That is 1,900 private hospitals that agree to take patients in time of need. And that's all coordinated through us, DOD, and VA. So it's an amalgam of a variety of different systems and a variety of different institutional and organizational constructs that we have to work with. And Skip, I'm impressed with your numbers of the patients you see and the volume that you see and your beneficiaries. We have 330 million beneficiaries in this country, and it ranges from Federated States of Micronesia to Puerto Rico and the Virgin Islands, in Alaska to Florida. And there are some very sophisticated systems out there that we support, and there's some systems that quite aren't there yet. And so we have that we have to deal with. And one thing I've learned over the past couple of years as we've responded to multiple hurricanes in 17 and 18 is the healthcare system is incredibly dependent upon other infrastructure to take care of patients. We cannot run hospitals without electricity. It's just that simple. The generators that are in hospitals tend to work for a couple of days, but they're not meant to last for 3 weeks or a month. And those generators are dependent upon fuel, which is dependent upon a transportation system, which is dependent upon tanks that have to be emptied, which is dependent upon electricity. Okay, so we're incredibly dependent upon electricity, communications, road infrastructure, IT, water supply, and sanitation. And if we don't have those, that all impacts the care that's delivered at hospitals or necessitates a movement of patients to a place where they can receive better care. In our NEMS system, our teams provide the care, and we have specialty teams. Most of our teams are acute care teams, but we do have what we call the Disaster Mortuary Operational Response Teams, the DMORTs. And their job is to support local coroners and medical examiners in identifying victims through family assistance centers, as well as a scientific process to come up with a positive identification. And that may not happen as fast as people would like that to happen. But if you misidentify one person, you've misidentified two. The person you've misidentified and the person who hasn't been identified. Okay, and is that the person? And that happened in Joplin, Missouri, based on a family coming in and visually identifying what they thought was their relative after the tornadoes out there. They got cleaned up and they went in to view the remains, and it wasn't the right person. So there's processes that take time: fingerprinting, identification of medical implants, dental records, and you just can't go in Joplin. You could not go to the local dentist to get the dental X-rays of someone because they were blown away. So there are complications that take time. But we try in NDMS and in ASPR, we try and use objective data to assist us in what we do and how we respond, and what our team composition is like, and what our formulary for our teams is like, and our approaches and our plans. And for instance, NDMS was set up for acute care. People who are traumatized from earthquakes and other disasters of energy, and they didn't focus much on the primary care piece. And frankly, the healthcare system has evolved over that time as well, from inpatient to more outpatient care. But what we've learned in responding to the multiple hurricanes and wildfires that we've done is that shelter care is important, supporting shelter care. So we created things under Admiral Vanderwagen like federal medical stations that provide a lower level of care for people who have chronic illnesses, don't require hospitalization, but either don't have a home to go back to that's suitable, or their home's not, or they can't go back there based on their medical condition. So we have federal medical stations. We've geared our teams and our formularies for mental health and other things like that. But the reality is we haven't responded to an earthquake in quite a while. And that could change the whole dynamic. Our system has changed because what we respond to most recently over the past 10 years has been something that doesn't require us to have surgical capability in any great degree, intensive care capability. Now, as we plan for some of the 21st centuries that my boss, Dr. Cadlick, talks about, we're going to need that, and we're doing that. But the reality is, if you just counted the records that we have and the discharge diagnoses that we see, it would be, you guys don't take care of acute patients and shouldn't do that. So we adjust, but we have to keep in mind there are other threats that we haven't seen in a while. We use electronic health records, and that works most of the time when we have satellite links or communications links, but sometimes it doesn't. We have a huge compliance issue with our electronic health records. It just, providers don't like to use them, and providers in the field really don't like to use them. But we try and use them, and we try and get data. And during the Haiti earthquake, we received data from our electronic health records and an infrastructure that was severely compromised that said we're seeing more kids than we thought we needed to see, with some illnesses that we thought pediatricians needed to take care of. So we were able to quickly, geologically speaking, get pediatricians to Haiti to take care of sick kids and injured kids. Mental health issues. In recent hurricanes that we responded to in the past few years, we saw people overdosing in the shelters. So we figured we need to adjust our formulary for that and some of our equipment. The other thing about kids, and a more longer-term goal, is we've initiated a pediatric pilot project that is looking at pediatric disaster health care. And we're looking at up to 2 sites that will be able to help us pilot what pediatric disaster health care should look like. And then we'll take those best practices and the challenges that they find in our pilot sites to be announced, and try and build that into our healthcare system and what we do at ASPR. So we're taking care of what is traditionally seen as a vulnerable population. Other uses of data that we have a program called Empower, and it uses CMS claims data for durable medical goods that can help pre-event or post-event identify dialysis patients, people on home ventilators, home and dialysis, so we can identify them and move them out of harm's way before or after the storms. And it uses CMS claims data. I know Dee is and a lot of other people have used that, and we're using it now in response to Hurricane Dorian. And that's a really essential piece of our response now, is Empower there's a lot of requests for it. It works. It identifies the folks and enables us to take action with them. There's other things that CMS claims data can help us. Emergency department visits. We can almost predict when recovery is going to start based on looking at the number of emergency department visits as they dwindle down after an event. And we can say, okay, here's the day when it's going to happen. We can trend those data, and we can help get the recovery process accelerated and started, and we can pull our teams out then too, and we have objective evidence to do that. We have a disaster science group in ASPR that looks at other large components of data that is interesting, using our data and using hospital data to look at what happens after wildfire, not right where the fires are, but downwind, and what the unhealthful air means to hospital workloads and emergency department workloads specifically, and more to follow on that. And then finally, post-Katrina, we ran out of ambulances. We didn't have enough ambulances, so we did a study in Louisiana, literally from Mississippi to Texas, that looked at south of I-10, that looked at how many ambulances were needed and what hospital, their capability of sheltering in place and the ability to evacuate. Dr. Vanderwagen was instrumental in setting that up. And we found out that probably 300 ambulances is what we needed, and some paratransit buses to move people who didn't require ambulances, and let's throw in some aircraft, rotor wing aircraft for that. And so that was the start of the National FEMA ambulance contract, that it brings ambulances into an affected area within 24 hours. It's important today because we're activating that as you look at the path of Dorian as it goes up the spine of Florida, projected to go up the spine of Florida. Mutual aid is non-existent because everyone has to hang on to their equipment, because if they send it to Miami, then they won't have it when the storm moves north. So objective data analysis, and then trying to develop a program that helps meet that gap, fill that gap, and provides better care for patients. We have challenges, interoperability of systems. In our DMAT tents, or our medical sites, we're often working beside Medical Reserve Corps, VA, local volunteers, and hospital personnel and EMS. And it's a purple suit of people in there trying to take care of patients. So one health record system doesn't work, or we use the hospital's record system if that's what they want. Timeliness, for us, death is a lag indicator. We get it long after we need it, and cause of death is really a lag indicator for us. So we can only plow that information back into future events, not the last one, which is okay, but it doesn't necessarily help us early on. And we count our CDC surveillance partners to be able to say this is the normal level of death. This is above the usual. Sharing of data, though, is an issue. I mean, those of you in the state health departments or local health departments know you don't like to share your data with the feds, because we'll do stuff with it that you don't want us to do. And same with hospitals. Oftentimes there's misunderstandings about HIPAA and what they can share and what they can't, and that's an education issue. And then there's skewing of data. And I use the example, I worked with CDC on a analysis of the real-time analysis of the medical load after the Oklahoma City bombing. And it turned out that, rightfully so, all the sick people came to the hospital, all the really injured people came to the hospital, but there were reports of other people out there. So to really get a complete picture of what the injury spectrum was, the Oklahoma Department of Health made it a reportable illness, reportable disease. So anyone who was seen related to a bombing injury got reported, and they were able to use those data to better analyze what was done. And then patient movement. I mean, again, John and I went to Las Vegas a while back to talk to them about their nightclub shooting, and traditional EMS did not bring a lot of patients to the facility. They either self-transported or were brought there by someone else. Those kind of data get completely lost. I mean, they don't exist. And then, if we have to move people across the country to get care, some of our big events, how do we track that? That's enormously hard. So, we think that, death certificates there should be a little, kind of environment of the death checkbox, that if this is something that the ME or coroner should look at, they should be able to do that if you're a practitioner signing a death certificate. But we also think that regionalization of disaster care, this is my sales point here. We've embarked on a pilot program for regional disaster health response. And multi-state regions where there's centralized situational awareness, there's sharing of data, there's interoperability that helps collectively that region get situational awareness and share data and understand what resources are available and what resources are being consumed. And our sites are at University of Nebraska Medical Center and Massachusetts General Hospital. They're finishing up their first year. We've extended them for another year or two to continue on in that work because we think it's an important way to go. So again, that's some of the data we have, some of the challenges we face, but those are the kind of ways ahead that we're looking at ASPR.